I want to look now at ventilation-perfusion ratios, which are very important in an examination of how the lung works. Alveolar ventilation is the rate at which air is reaching the alveoli, and you can measure this in litres per minute. Perfusion is the rate at which blood is reaching the alveoli, which can also be measured in litres per minute. So if we take the ratio of the alveolar ventilation to the alveolar perfusion, the units will cancel and we have a dimensionless ratio. Now, under normal circumstances, the average ventilation perfusion ratio for the whole lung of a person is somewhere around 0.8, which means that we have slightly more perfusion of the lung than we do ventilation. Now, that's absolutely fine. There's no reason why you would expect it would have to be 1. It turns out that 0.8 is entirely appropriate for what the lung needs to do, and that the oxygen is appropriately absorbed into the blood and the blood carries it away to the rest of the body. Now, ventilation perfusion ratios can be altered under different circumstances, and I'm going to look at two different things. We're going to start off by looking at how ventilation perfusion ratios vary across the lung under normal circumstances due to the effects of gravity, and then we're going to go on to look at pathological circumstances and what they might do to the ratios. So if we start by looking at gravity, we'd have to think about how gravity affects ventilation and how gravity affects perfusion. And the reason this is an issue is that humans are relatively large mammals which are vertical and are exposed to gravitational acceleration because we're on the Earth, of course. Well, let's start with ventilation. And the lung is contained within this sealed pleural cavity. But because of gravity, the lung tends to flop down a little bit. Now, the way that I look at this sometimes is to imagine the lung is like a carrier bag. And you can imagine a nice carrier bag from the shops which has got some produce in it, and you're holding it from the top of the bag, and the produce is in the bottom weighing it down. And you could imagine perhaps that the bottom of the bag is being supported because it's resting on a table, and you're lifting it up from the top. Now, this is a little bit like the lung within the chest cavity. The lung is resting at the bottom on the diaphragm, but it's prevented from collapsing because it's held within the pleural space, and that can't expand too much. Okay, well, if you think about our carrier bag, right at the top of the carrier bag near the handle, it's all really stretched out. The plastic is really stretched, and it's not very easy for it to stretch very much more. In physical terms, we would say that this has a very low compliance, which means that you can put in quite a lot of pressure and you're not going to get very much change in volume. So the top part of the lung is stretched out and there's limited capacity for it to stretch further. But the bottom part of our carrier bag is much more flexible. There's a lot more slack in it. And that's the same as the bottom part of the lung. That's a bit more flexible as well. And as a result, the compliance there is relatively high. And what that means is it's quite easy to expand it if you change the pressure across it. So, the top of the bag is stretched out, the bottom of the bag is floppy. Now, if you think about the lung, if you expand your thorax and you try to expand the lung, if the top part of the lung is already quite well stretched out, it doesn't expand very much. And that means not much new air gets into the top part. The bottom part of the lung is more floppy, it can expand much more, and that means that more of the air that you breathe in gets into the bottom part of the lung. So in terms of ventilation, the amount of gas coming into the lung per minute is higher at the bottom of the lung than it is at the top. So the ventilation, as you move downwards, increases. Let's think now about the perfusion, the blood supply to the lung. Well, the blood is provided by the heart, which is also in the chest cavity. But if you're sending blood to the top of the lung, you're having to send that blood against the influence of gravity. So at the top of the lung, the blood is at a relatively low pressure. At the bottom of the lung, because of gravity, the blood is at a relatively higher pressure. Now, the flow of blood through blood vessels can be determined by Darcy's law. Flow is equal to pressure gradient divided by resistance. And if at the top of the lung the pressure is low, the blood flow rate is going to be relatively low as well. That means low perfusion. At the bottom of the lung, the pressure gradient is higher, and that means higher perfusion. So what we're saying is that the perfusion also varies in different parts of the lung according to gravity. And the lower you go down the lung, the higher the perfusion is as well. So what we have is a situation where both ventilation and perfusion are affected by gravity. At the top of the lung you have less ventilation and less perfusion. At the bottom of the lung you have more ventilation and more perfusion. But it turns out that gravity affects the blood more than it affects the lung. In other words, the effects on perfusion are greater than the effects on ventilation. At the top of the lung, ventilation is reduced, but perfusion is reduced more. And what that means is that the overall ratio is higher than it would otherwise be. At the bottom of the lung, ventilation is increased, but perfusion is increased relatively more, and that means the ventilation-perfusion ratio is lower than it would normally be. So the fact that the average ventilation-perfusion ratio across the whole lung is 0.8 hides the fact that there are regional differences. The ventilation-perfusion ratio at the top of the lung is relatively high. You've got relatively more ventilation if you think about it. The ventilation-perfusion ratio at the bottom of the lung is relatively low. You've got relatively less ventilation. Now that's absolutely fine, it's absolutely normal, and we deal with this without any difficulties. But it does have a certain amount of clinical implication. For example, we've said that at the top of the lung, the ventilation-perfusion ratio is relatively high. It's a little bit over-ventilated, and that means that the oxygen levels in the alveoli are slightly higher than they would be at the bottom of the lung. And that's a better condition for tuberculosis bacteria to survive. They like high oxygen levels, and so tuberculosis tends to occur towards the top of the lung, the apex, for that reason.